Good afternoon. This is session number 2. How's everyone doing so far? We're looking forward to a great panel, and I feel like this panel is awesome. No pressure, okay? Told them we got to do better than the last panel, okay? They did well. We got to do better, okay? So no pressure, okay? My performance review is after this show, so help me out. So the first question really is to set the context for the group is, today 7 out of 10 Americans are overweight or obese. By 2030, that's going to be close to 50%. Okay? It's also, and so today in the world, 1 billion people are considered overweight or obese. Most have tried repeatedly to lose weight and keep it off, only to fail. We've heard throughout today's discussions in the last panel, many suffer from medical conditions that are linked to obesity, including diabetes, joint and back pain, and heart disease. And those conditions often improve with weight loss. With the approval of GLP-1s now, last week, where they've got approved for the reduction of major cardiovascular events, and also we now have them approved for weight loss. Sarah, from your experience working with a large health plan, how are you approaching building weight loss management solutions for employers and members you serve? And then the second question, on top of that, because I know you're going to answer that one so well, what do you see as the opportunities and challenges to launching those successful programs? I'll turn it over to you.
So as we've been talking about today, everyone's talking about weight loss. You can't be living in this world and not hear about it. Sustainable weight loss is critical, and so many people have tried time and time again and aren't successful. So with our clinical programs at Blue Cross of Idaho, we really have a holistic model that has a care plan surrounding our members to help them get the care they need at the time they need it and when they're ready. So part of the care team is a registered dietitian, certified health and well-being coach, registered nurses, their provider, and then also digital tools to allow them to have education, download data, and things like that when our team isn't working. So very critical to be holistic, meeting our members where they are, identifying them early before they may continue on to risk. We've had a diabetes prevention program in place for 8 years, in addition to a weight management program. And so last summer, we started looking at making our weight management program more robust so that we can reach more people when they need support and when they're hearing about GLP-1s everywhere they go. There are real health benefits when people lose even 5% of their weight, and so it's critical to have that in place with the weight management program as well, and ensure that they can reach back out when they're slipping or when they need assistance. So incorporating moving more, eating nutrient-dense foods, helping with tobacco cessation if needed, mental health is huge, and managing stress, all of those different areas that people really need help with. And oftentimes, the outcome is weight loss when you're not even focused on the scale. I'll share a recent poll where employers were asked, where does your organization stand on weight loss medications? One of our vendors put this poll out to thousands of clients. 33% of organizations say they will cover certain medications tailored with a behavior program as a prerequisite. So the lifestyle change program that I talked about earlier. 33% cover medications without a behavior program and had been maybe last summer and have now turned this off and are trying to figure out what to do now. 17% are not considering coverage, and then 17% are. So Javi asked about opportunities and challenges, and we've kind of talked a little bit about, I'll start with challenges. So really access to care, those members that we have that aren't utilizing any provider or anything, so we don't have data on them. They may not know about our programs or how to get in touch with our team. Low engagement, so again, people maybe who don't know about the program, who are needing support but don't know where to go to get it. And then social determinants of health that we've talked about a lot today, so I won't go into that a ton. And then opportunities for a successful launch of programs are getting leadership involved, spreading the word to ensure that people know about the programs, educating and advertising about the programs. So some of ours, we send letters, we ensure that people have downloaded our app and know what benefits they have. So when they're in need, they can just go there to get it. And then incorporating clinical outcomes and having assessments pre and post so that you can measure success. So lastly, with this question, I think the key to helping people sustain weight loss is engaging early and having a mix of human coaches, like I mentioned, and digital solutions to really help members meet their goals.
Thank you, Sarah. Question for you, Stacy, as an employer. Over 92% of employers cover GLP-1s for diabetes. That number is less than 50% today for weight loss. In the competitive marketplace, what do you see as the benefits and risks associated with covering weight loss drugs and supporting services like gym packages, health meals, coaching that historically have been excluded from the benefit?
Yeah, we know we've talked a lot about the benefits of weight loss today, right? Decreasing those comorbidities. So we know what the benefits are from the employee and their family's standpoint, and the benefits for the employer, right? Reduced absenteeism, presenteeism, all of those things. On the risk side, right, it's all about the cost perspective. Just recent hot off the press data from our pharmacy consultants, we had a 47% GLP-1 for weight loss abandonment rate last year, which equated to about a third of all of the spend that we had for weight loss GLP-1s. And that's not even factoring in the off-label diabetic GLP-1 usage that we know is out there, but is more difficult to quantify. I think the longer piece, and I'm sure we'll continue to talk about this, as Sarah already mentioned, is that more holistic behavioral management, lifestyle adoption that needs to be surrounded with offering a GLP-1. And there is a component from an employer standpoint of you're either going to pay now or you're going to pay later, right? And so balancing that piece of it, but from a financial leadership perspective, they only want to know what you're doing today to decrease those costs. And we know with the outcomes of GLP-1s and reducing those comorbidities, that has a little bit of a longer tail. And so when you're expected to manage your medical and pharmacy trend to something ridiculous like 0 to 2% perhaps, that there's no patience for that longer term, those longer term outcomes to sort of present themselves.
No, I have to agree with you, and I think a couple things. The panel before, right, just to make the connection, right, Helen was saying how important it is. The data you're sharing is very consistent with her data. There's an issue with adherence. Obviously, these drugs have very well-documented side effects, right, that lead to that. But if we don't think about the total cost of care, to your point, right? So yes, these drugs are expensive, but if we think about how much employers spend for weight or obesity-related secondary chronic conditions that we've talked about, then I think we're losing an opportunity, right? And I think that, we also heard in the previous panel, there's challenges with reimbursement of GLP-1s, and some pharmacies don't even stock it, right? So I think we just got to think about how we kind of uncouple a reimbursement strategy so that it's not just based on the cost of the drug, right? But it's also what other attributes can we collect and that pharmacists can play a role, because this disease state is it's an epidemic, and it's going to have a profound long-term financial impact if we don't manage it. It's going to be a tsunami, quite frankly, right? Just with the sheer number of people that are overweight. But a question for you, Dr. Graham. From a physician approach, which patients are the right ones to start on GLP-1s for weight loss?
According to the stats, everyone, right? If it were 1 billion people worldwide, or actually, it's not overweight and obese, it's obese. So 1 billion people in the world are obese. So therefore, everyone, right? Anyone over 65, 85% of people over 65 have a chronic medical condition. I just want to kind of level set a little bit, because it's really interesting. I spent a lot of my time, let me give you a background really quick, right? So first 15 years of my life, I was an academic physician working in large academic settings, teaching doctors, rose to the rank of program director, and in my last position with the last healthcare system, as opposed to the most recent one I just started 9 months ago, I was their chief wellness officer. I go back because there seems to be, although the title of the conference is Forward, we seem to be going back, right? And one of the things I always like to remind people is how this whole thing started, right? Is that I want to focus on more about why, as a physician, why we went into medicine. I'm going to jump around a little bit because I heard so many things this morning, and I have to just touch on it. The last panel just brought about the burnout rate amongst pharmacists. Medicine is right behind them. So 600 doctors kill themselves each year, not because of what they do, it's how they do it. And so this is a big sort of tidal wave that's happening as well. So that if we don't have doctors prescribing medications because of the burnout epidemic, we don't have pharmacists filling them, what's going to happen? So to answer your question, right, it depends, right? So the idea of any sort of medication is supposed to be used for a short term, right, ideally, until the patient develops a therapeutic lifestyle that supports that diagnosis. If anybody's been in medical school, the first thing you learn about treatment algorithms is that you're supposed to optimize and prescribe 6 weeks of therapeutic lifestyle change. So for my physicians out there, when we talk about evidence-based medicine, it doesn't jump right into the medications. Evidence-based medicine starts at the patient encounter talking about the therapeutic lifestyle changes. So after leaving academia, I wanted to prove to myself that why I became a doctor. I became a doctor to reduce patient suffering. And we don't have to be suffering from the environment we live in. We can actually take ownership. But the problem is that doctors are the last person to talk about sort of diet, exercise, sleep, and happiness. And that's why we started a company called Fresh Medicine, because we believe that medicine needed a fresh change, a fresh start. And it stands for what we believe are the 5 recipes in the 5 ingredients in a recipe to health: food, relaxation, exercise, sleep, and happiness. So think about the last time you saw your doctor and they talked about those 5 important ingredients. Now, as a physician, I can't do it alone. That's why it has to be a team-based approach. As Sarah was mentioning, in a health plan, so a health plan offers sort of these wraparound services. But think about if you're a physician or your doctor's office offered, right, the wraparound services like nutrition, exercise physiology, sleep hygiene, positive psychology, things that actually can induce behavior change, not at the plan level, but at the provider level. So that's why I'm really excited to announce that as of last September, I was hired back into a large healthcare system who truly believes that medicine needs more health and care. And that is only driven by how we practice medicine. So in our health system, we're going to be foundationally providing these sort of services that bring everyone up to the point of health and well-being, and use medicines only when they're appropriate for the shortest amount of time until the patient is supported to get off of them. Now, I love my pharmacist, I love drugs, drugs work, but if you think about it this way, if you lose weight, you gain health. Just think about that.
Well, thank you for that. Anand, your organization has a very cool digital platform that really targets some very key disease states. One being weight loss. But I mean, from your perspective, what is and bridging back to our earlier conversation to give shout outs to the AI machine learning teams, what is the potential for AI as it relates to personalizing weight loss journeys for patients that you guys may be experiencing?
Yeah, no, great question. Maybe I'll give you 30 seconds of context. For those of you who may not know WellDoc, we are, as Javi said, a digital health company, really with the primary mission of helping those who suffer from cardiometabolic conditions. You think of the usual suspects: diabetes, hypertension, heart failure, prediabetes, weight management, mental health management, sleep management. It's to help them achieve better outcomes, live better lives, and reduce their personal burden, if you would, to the healthcare ecosystem at large. We do that by provisioning what we call software as a medical device, or what the FDA calls software as a medical device. So these are apps you download to your phone, but these are medical grade apps. They're 510K cleared class 2 medical devices that actually take in a plethora of data. Could be their blood pressure, could be their weight, could be their blood glucose, could be what they ate, could be a picture of their food. And it provides them in the moment coaching on what to do, but then it provides them insights over time, longitudinal insights to say, aha, noticed a pattern here, let's work on this, et cetera, et cetera. And it's all software driven coaching. And then of course for the healthcare provider, it takes all of that data, runs it through evidence-based guidelines, and tells to the doctor basically, hey, here's where they were 3 months ago, here's where they are today, here's what's changed, here's what evidence suggests you should do, but you're the doctor, do what you think is right for your patient. When we do that, the outcomes that we achieve are actually pretty remarkable. You're talking about a 1 to 2% hemoglobin A1C reduction. For those who start with an A1C above 9, it's typically 3 points. That's remarkable because the average of the top 15 drugs in diabetes achieves is minus 0.83 today. So it's like, okay, that's pretty cool. You're looking at a 7 to 12 millimeter systolic blood pressure drop and a 6% weight loss. We're like, okay, that's a great starting point. So I'll personalize the answer to this, Javi, which is, some of you may know I'm a type 2 patient myself. And I remember when I was diagnosed, it was a little bit of an upside down in your life. And all of a sudden you got to do things differently. And you got to manage your glucose and your food and your exercise and your sleep and your this and that, the 360 of diabetes, right? And there's this wee little thing called life that gets in the way from time to time.
Don't know what you're talking about.
No idea. And I'm a little bit of a nerd because I'm a little bit of a nerd. I would graph all my stuff and take it to my doctor. What's the doctor going to do in a 3-minute office visit, right? I wish my doc had the time to give me coaching on, hey, this is why you need to manage your weight, this is why you need to manage your sleep, etc. There is no billing code for, did you bring your blood glucose meter today? So I could download and see, there's no billing code for that, right? And if you ask an overworked, underpaid doctor to do one more thing that's orthogonal to their workflow, they won't do it. It doesn't matter how cool it is, they just won't do it, and they shouldn't do it. And so what we've learned is that when you take, I'll use another acronym, we call it MEDALS, going back to what Sarah introduced. M is medications, E is education. Okay, think of how well codified these cardiometabolic conditions are from guidelines, right? Practices, best practices. D is diet, of course. And you start to think about, okay, you're hypertensive. Well, okay, there's this thing called the DASH diet, right? Okay, at least focus on fruits, vegetables, obviously focus on sodium content, etc. A is activity, right? L is all your labs, things that you can physically measure, weight, blood pressure, blood glucose. And of course, S is your symptomology and all your psychosocial, because you don't want to lose sight of that. So now, in your left hand, you have, even after 30 days of engagement, you have a very rich data set of what's actually happening with that member. You actually have data that you can then feed your AI models, because that's exactly what we do, to then use that data to say, okay, is this person going to achieve, in a very simplistic binary classification for those of you people who are nerds like me, just classify an outcome. Did you get it or not? 5% weight loss, to your point, Sarah, right? Did you achieve it or not? Or will you achieve it or not in 90 days, 180 days, etc.? You can use that data judiciously to make the best therapeutic pathway decision for that member. And you know what? Hey, if you're going to succeed, you're on a path to succeed, great. No, you don't need a GLP-1. But if you know what, if it ain't going to work, no amount of running around the block is going to help, okay? And then you need a GLP-1, you need a GLP-1. So there will be decisions that are data-driven. You're using the data to illuminate treatment. I say this sometimes tongue-in-cheek, but I'm dead serious, guys. When you look up in the nighttime sky, right, and you see a point of light, and you're like, oh, it's a star. Could be a planet, but you know, it's a star. And then you look in the Webb telescope, and you're like, oh my God, there's like 6 galaxies. Digital to weight management and to GLP-1 management is to the doctor and the patient what the Webb telescope is to the astronomer. It lets them see things that are unseen by the naked eye. It lets them see things that are happening in between those office visits. And so AI, in many ways, because we know it, GLP-1 is great, it's fantastic, but it comes with this plethora of problems. Okay? There's side effects left and right. May not be right for everybody, but I can use those side effect patterns.
They're really cheap.
The side effects, you have the cost of it, of course, and then you have the cycling. We talked about it in the last panel, is this concept of cycling, right? I think AI and digital health hold it's kind of the ace of spades here that can help. And it's not the be-all and end-all. It has to be used, Sarah and I were talking about this earlier, these things have to be used in conjunction with care. The care pathways that the providers and the provider organizations and the care plans administer for their patients. And that combination of digital and human care, it's like a 1 + 1 = 3. It's a powerful model. And I think that's the way AI is going to help. It's going to illuminate new pathways.
No, that's, I agree. Any of the panelists want to comment on that? If not, we'll move to the next question.
Again, I think if I had a telescope and I had time, you know, I'm in New York City too, by the way, so I could look at the sky all night long and I don't see any stars or anything else, right? So it depends on where, with the vantage point you are seeing the world, and also the time to look in the telescope, right? And in reality, the reality is this: the way doctors operate right now, there's just simply no time. There's no time to do anything that's aspirationally remote to what we're talking about. So these clinical models that you're hearing, you know, from digital platforms, from health insurers, from employers, it starts at the doctor's office, and we have no sort of clinical support team that is reimbursable the way we think about it in today's market. We're getting closer, right, with nutrition and dietitians billing for MNTs or group visits, shared medical appointments. We're getting there, right? But I think it takes sort of this concept that you're hearing is the revolution in healthcare to really provide the care that we all want and deserve and pay for. Because I don't know about you guys, but my health insurance premiums every year keep on going up and going up, you know, and I have the ability to afford it, number one, and I'm a doctor. I can prescribe anything to myself, right? Yeah. But I maybe just pivot a little bit. A lot of my time I spend, besides being a doctor, I'm a chef. So I'm one of these unicorns, right? People talk about food is medicine. I am food is medicine. I went to culinary school so I can understand the biggest problem we have in our society, right? And it really is really important to kind of focus on that a little bit, because a lot of this stuff we talk about, even this title, weight loss management or diabetic management, I firmly believe that with the right sort of therapeutic team behind it, giving the therapeutic lifestyle changes that are evidence-based, all this stuff can be reversed, right? So it should be diabetes reversal program, hypertension reversal program, weight loss reversal program. And that's only going to happen if we actually put, like I said in my practice, a food-first approach. But the reason why we're overweight and obese is just not because of our food. It's because of how we love, how we exercise, how we don't sleep, how we're unhappy, how we're so depressed. So looking at either a drug therapy for a complex thing like weight loss, or a food approach for just weight loss is never going to get us there, because people's root cause of obesity is larger than just the food that they eat. And believe me, I love my food. I love prescribing food as medicine, and I spend a lot of my time down in DC at the city, in my own city, New York City. And if you're following what's happening in New York City in the food system, in the food environment driven by our mayor, Mayor Adams, right, we're going to be changing a community-based approach to how we address food insecurity and at the same time these food-borne illnesses. And it's not salmonella and everything, it's everything at the end of our fork. And without that sort of comprehensive approach by using optimizing community, we're not going to get there. We're just going to be managing fat people all our lives. We're going to be managing diabetics all our lives. And until we start really getting serious on why we are obese, we're never going to get there. And we're going to be throwing more drugs, more doctors, more pharmacists, more health coaches. And until we really get serious about why we are obese, we're never going to get to the final answer.
Yeah, if I can piggyback off of that from an employer perspective, education underpins a lot of what we're talking about. And I know I'm not alone in this. I don't have a team and the resources to be able to do this on our own. Couple that with the fact 25% of our workforce in the US and Puerto Rico is manufacturing, and the social determinants of health and access to resources, financial and otherwise, play a huge role in this. And so we're really incumbent upon the ecosystem to help drive this forward.
Just one comment to add what you said, Stacy, and then I have a question back to you guys, which is, in the old world, you used to go to the taxi stand. Today, Uber comes to you, or whatever, Lyft, right? Yeah. In the old world, you used to go to the ATM to get cash. Now Venmo or Zelle or whatever you use comes to you, okay? If you generalize it, you went to X, but X now comes to you, okay? That's a powerful paradigm shift that digital enables. Now you're talking about education. You're delivering bite-sized, moment-by-moment, relevant, both temporally and contextually relevant information to a patient at the point of care. I just had my third hypoglycemic event, and I got a thing about exercise. I'm like, no, that's stupid. I'm gonna ignore it. Whereas if I got a video at that point in time saying, hey, there's 3 things you can do to avoid hypoglycemia, you're delivering educational content. So I think your comment about education is spot on. We have ability to do it. So here's a question for you guys, which is there an appetite with the payer community? These models are only as good as you train them with rich data. We all know weight management and diabetes and things like that are a little bit of a wastebasket term, because person A's weight management and person B's weight management with completely different genetics is completely different. Their pathways are different, et cetera. Is there an interest? Is there a propensity for people to start looking at, what? We should start feeding in genomic data to these models, make this genomic data available, to power these models to look even further, to then make it very clear who is right for a GLP-1, who's not. I'm curious what the community's thoughts are on that.
It's a great question. I know you didn't want to say, did they have the appetite? Because I know this is a GLP-1 one.
They are hungry for change,
Sarah.
though. They are hungry for change.
So we recently enhanced our diabetes program. We call it condition support. So it's diabetes, cardiometabolic conditions. We added in a robust model and algorithm to find members who are more at risk. Turned on the WellDoc application, and our members are loving it, and our care team is loving it, having that more improved coaching conversation to be able to talk with our members about exactly what the member's seeing on the app. So it's a pretty cool solution that we've just turned on. We're also looking at turning on the weight management piece of that, so that instead of picking which condition you have, say diabetes or heart failure, you'll have the option to pick weight management instead. And so it's this whole new world of getting that. We all have our phones at our fingertips all day long, and just having a few seconds to get that information and education, to Stacy's point, to our members when they need it, and then teaching them what their different data points are giving them and how they can make them better in the future. So
It's good. Thank you for that, Sarah. So getting back to the medications and the route so that we get credit for a GOP panel here. Dr. Graham, what is the mindset of your patients when they're approaching starting the GLP-1 therapy? Do they want a one-time reset? and commitment to, or, are they committed to changing lifestyle? Do they expect the GLP-1 to do all the heavy lifting? Like what is that mindset usually that you see with your patients who start GLP-1s?
Yeah, I see GLP-1 as like the new, and I think it was mentioned earlier, the new Lipitor. So when the statins first came out, right, it was like, I'll have my Whopper, but I'll have my Lipitor chaser, right? So it didn't really change any sort of behavior. And when you look at sort of how drugs are used, right, there are some people, right, that just wanted to use it like that, right? I really don't want to change anything. I want to get my numbers right. And now if anyone has been a patient, right, and I can tell you this from somebody who's been practicing medicine for 25 years, when someone changes their lifestyle, and particularly their diet, and I can go, if you can remind me just about what a healthy diet is, there's no such thing as a healthy diet for everyone, right? It's so individualized. To your point, you're talking about food sensitivities, you're talking about culture, you're talking about love, you're talking about community, you're talking about so much behind that sort of prescription of eat a healthy diet. If I tell you to stop smoking, that's sort of binary. But a healthy diet to Javier is different than a healthy diet to Sarah, to anyone out here. So I think there are certain people, right, that have this sort of idea. My father-in-law, who passed from esophageal cancer, he used to call us and say, you know what, I went to the doctor's office and he said, my blood pressure is perfect, my cholesterol is perfect, failed to remember that he was on 6 medications to control that, right? And he died of esophageal cancer, right? So there's this concept of like, if my numbers are good, I am healthy, right? But that's not even the tip of the iceberg. When you are changing your life, right, and providing yourself the opportunity to be healthy, there's such a pride that comes to it, And so when Ed, before he passed away, got off the statin, because he did one way to do this, he went whole food plant-based for 6 weeks. It was too late, okay? He went whole food plant-based with more of a green Mediterranean spin to his diet, right? That sort of pride that people get from coming off medications, it can't be understated, right? When a diabetic is no longer needed insulin, there's such a pride. And I do see that in GLP-1s, okay? So I see people all the time, and there's constantly, a diet, and the Rastafarians that in the audience there, they call diets because diets die, right? And so they call the food-based approach live it, right? So how can I live with this sort of diet that sustains my health and well-being for the rest of my life? And so, to your point, it depends. Some people, and I've seen amazing sort of, again, that pride that I no longer feel that aches and pains in my knees because I just lost 60 pounds in 6 months. By the way, I'm good, but I'm not that good, okay? So 60 pounds in 6 months is an incredible weight loss. It changes people's lives. It changes people's mindsets. It changes people's daily activities. But at the same time, the reason why I think your point about how there's such drop-offs, right? I'll give you a real story. So I have this cute little beach bungalow in the Rockaways of New York. If you ever flew into JFK, you fly right over our house every day, every 3 minutes, all day long. But what you'd realize is this woman, Stacy, she was wealthy. She had this little tiny bungalow. But every morning, okay, and she was probably about 70 pounds overweight. She started on GLP-1. She would brush her teeth, inject herself, take a shower, and guess what she was doing in the shower? Vomiting, because she had gastroparesis, dysmotility, second to GLP-1s. But by the end of the summer, right, first half summer, she lost 30 pounds. Second half summer, she gained everything she lost. And you heard my saying before, you lose weight, you gain health. You lose fat, that's good, but you lose protein, bad. And that's how it all comes back, okay? So you lose protein and you lose fat. So to give these sort of drugs without that sort of exercise physiology, physical therapy, health coaching, focusing on the right food for you, I think it's very myopic. And I think we're never going to get to that sort of end goal if we're just going to be giving people drugs. The same sort of thing in cardiometabolic risk factors.
Yeah, I was reading a JAMA study that I think you sent to me during our prep sessions that I found super interesting, and it was the concept of GLP-1 in combination with food as medicine strategy, right? Because what we normally see is when people stop GLP-1s, their weight comes back, right? But when we combine it with a food as medicine strategy, and in the study they said that the food as medicine cost anywhere between $250 to $350 per month, medicated food plans. And if you think about the cost of GLP-1s, right, what they said was it's kind of you start with a boost strategy and you start the patient on GLP-1s, then you titrate as the food as medicine takes on, and then ultimately you maintain the patients on a food as medicine as they change their lifestyles, exercise, and all that. And it showed some remarkable outcomes, right? And from a financial perspective, we know it's very financially challenging for employers to have patients stay on GLP-1s for those that can tolerate it, right? So what are your thoughts on that?
So to be totally transparent, from a conflict of interest point of view, I am the chief health officer for a medically tailored meal company. You guys familiar with what a medically tailored meal is? So I'll give you a little primer here. So when you talk about food as medicine, there's sort of a triangle, okay? The tip of the triangle is a medically tailored meal. The second sort of body of the triangle is what they call produce prescriptions. And the third is foundational, is nutrition, therapy, and education, usually either by an RD and or a health coach. That's how we practice it at Fresh. That's how we practice, okay? So the medically tailored meals is this. You go to the doctor, and the doctor says, oh, you have diabetes, you have hypertension, you know, and on the way out, they're usually holding the doorknob, and it says, don't eat fat, don't eat sugar, and don't eat salt. And kindly, you kind of shake your head, and they walk out the door, right? And they're like, counsel that patient on therapeutic lifestyle changes, right? At the doorknob. But we believe, right, and this is why I entered this space, is because people are so confused about what to eat for the conditions that they have. Here's your medically tailored meal. The medically tailored meal is, as we call it, a performance kitchen. Designed by a chef, made by a chef, designed by a registered dietitian, and prescribed by a doctor. Now, 80% of Medicare Advantage programs have a food as medicine benefit on their program. Most insurance plans don't execute on it. Okay, so that's an important factor. Most people are entitled with a chronic disease to 270 meals per year. Let me repeat that, 270 meals per year they're entitled to. It's their benefit. And now all insurance companies, right, want that high star rating, and they're adding more and more food as medicine interventions. So let me give you an example. We're in Puerto Rico. I had a patient named Felix, true story. He was a salsero. You guys know what a salsero is? Not a guy who likes salsa, who dances salsa, okay? So a salsero dances salsa, and he sprained his ankle, broke his base of the fifth metatarsal. Very painful fracture of his pinky. He wanted to get back on the dance floor. His why was to get back on the dance floor, right? But he can't. I have to put him in a cast. The cast is your medically tailored meal. Use this, eat this for 2 weeks, for 4 weeks, for 12 weeks, okay? While they're doing that, they have a dietitian or a health coach supporting them in that sort of nutrition. Transferring them from a medically tailored meal, they've already lost weight. The reduction in healthcare utilization is tremendous, 16% at the time of intervention, to the point now we have to transition them, right? Just like rehab, I gotta put them through rehab. The rehab is your produce prescription. But I can tell you this, Felix, 68-year-old guy, never has cooked a day in his life. How am I gonna give him prescription? He doesn't know what to do with a head of cauliflower, right? So that's where the education comes in. I can give you a prescription for produce, but if you don't know how to cook or source it, you're never gonna use it. So that's how I see food as medicine in combination with GLP-1s. Going back to my first point about doctors, evidence-based medicine says optimize therapeutic lifestyle first for 6 weeks and then initiate drug therapy. Docs, right? Am I right about that, docs? That's what you're taught in medical school, but none of us do that. And I think we have to go back to the roots of medicine. If you remember, 2,000 years ago, let food be thy medicine, medicine be thy food. But we don't know we don't prescribe what we don't know. And doctors don't know anything about food. Okay, so that's how I see GLP-1s. That's how I see therapeutic lifestyle changes and food as medicine as an intervention that I think is going to change. I really believe that the food as medicine movement, if prescribed correctly, will change how healthcare is delivered in the next 5 to 10 years, with or without the use of GLP-1s.
I mean, thank you for that. And if we think about what's happening, you know, again, in preparing for this, I must have read through 30 different articles, but one that I read that came out of New York Times is actually the impact that GLP-1 is having on Walmart, on food brands like Doritos and Oreo cookies and all this. And I also think that we're probably going to see a shift on like what's on the grocery shelves, right? Like I think it's going to be that profound. And maybe we see a shift in hospital health systems, right? That they actually prepare and invest more in dietitians and weight loss related types of programs, because there's so many patients that could fit that bill, that maybe we just start seeing a change. Because again, I think it's a tsunami. I think that, as healthcare providers, we should figure out how to keep the healthy healthier, instead of just focusing on, okay, let's treat the chronicity aspect of healthcare. So we'll see what happens.
They hired me, man. A health system hired me to sort of help develop this sort of strategy. We're working with pharmacists too. And pharmacists, the other thing, if this food is medicine movement, you guys, pharmacists in the audience right there, they're also sort of this clinical care provider. They're providing care in food as medicine for their patients. And that's why you're seeing, we partner with Kroger, by the way, again, conflict of interest and stuff. So we partner with Kroger because they have that produce prescription in their retail store. So you have the pharmacist, you have the prescriptions for your groceries all in one shot.
I couldn't agree with you more. Last question before we go to Q&A for Stacy. As employers determine the best way to address this increasingly bustling market for weight loss drugs, and employers will have to grapple with whether to exclude GLP-1s for weight loss, like we saw the state of North Carolina have to do, or cap individual workers' lifetime spending on pricey treatments like the Mayo Clinic has done. Do you see this trend continuing? What other approaches should employers be thinking about, given the negative impacts obesity can have on total patient healthcare costs, presenteeism, absenteeism? You kind of mentioned a little bit that, and we'll wrap our panel up with that question.
Yeah, I mean, there's for sure a spectrum of options, and as I think about our, Medtronic specifically, our role in this, and what we've done, or maybe more accurately haven't done, we all saw this sort of coming, and lots of companies, ourselves included, didn't really act fast enough. And so, when I mentioned that 47% abandon rate earlier, that's not because there's a cost barrier. There's no copay on weight loss GLP-1s for us. And so as you look at the options, right, it's do nothing and then carry the burden, which, by the way, is not an option for us and likely most organizations. It's an option to put a lifetime limit in place, although I struggle with that a little bit because the data continues to show that, for some people, this sort of becomes a maintenance medication. And so if you put that $20,000 lifetime limit in place like Mayo did, that covers maybe a year and a half of a drug, and then what happens after that, right? So it goes back to, and then maybe the third option is there's lots of companies that have popped up, like a Wonder or a Virta, that provide that GLP-1 management. And the hope is that with that lifestyle approach underpinning all of this, that they don't get to the GLP-1 space, right? And so I can share a personal story. So I have been on a health journey over the last 6 months. My father passed away at the age of 58, almost 20 years ago. He had 3 strokes by the time he was 55. A combination of lifestyle and unfortunately not good genes. And so I saw myself going in that direction and looked into a GLP-1. Now, I don't carry our benefits, I carry my husband's, and they allow for 4 GLP-1 prescriptions per year. Well, that gets you like 4 months. That's nothing, right? So I thought, well, this is silly. I need to go a different direction. And so I found a program. I have a crazy lifestyle. I have 2 kids, high stress job. I know enough of what I need. And so I found a place, was not cheap, but that could give me everything that I needed. My workouts are delivered to me through an app. I have a menu of things that I know that are easy for me to eat, I can pick from, and I have been successful and have lost 30 pounds. Now, If I would have gone the GLP-1 space, I might have been in the same boat, but this has become more of a lifestyle. And I really think for employers, that's where it needs to start. I do think that there's a place for them to pay for and support that, but it has to be this holistic approach.
Inherent in everything that we just heard is this notion of personalization. It's not a one-size-fits-all. GLP-1 is just another arrow in the quiver of how a person is going to manage, with their guidance of their healthcare provider team, how they're going to manage their outcomes and get to a better place. And I think that notion of personalization is really, really important. And digital holds another ace of spades here, which is it lets you do it at scale. It's kind of like having your cake and eating it too. There are people who offer personalized GLP-1 coaching. It's very expensive. It's like basically having a coach in your pocket. It's maybe even more expensive than the drug. But if software can help you manage that, it's already it's a very scalable methodology, right? And so I think the personalization, the scalability, the data-driven approach is what's going to help us manage this conundrum of how do I afford it? Why? How can I afford it? Who's it for? Who's best for it? It'll help answer some of those questions.
And it seems like everything we've talked about is connected with what you just said. So thank you for sharing that. So we're going to open up the questions to the participants out there. Hopefully you've got a couple good zingers for us to answer for you. So we'll be on the lookout. You can raise your hand. If you can come up to the mic, that'd be great. We'd love to hear from you in 3D.
Anand, what are you seeing about coverage on digital therapeutics? What's the trend and what's the current state?
Yeah, you've probably heard a lot. It's a great question. You've probably heard, and there's been a lot of news about what they call prescription digital therapeutics, right? So the likes of Pear Therapeutics, who unfortunately went belly up, Achilles in the same boat. Just last week, Better Therapeutics is in the same boat. And so they're reticent about providing an individual code. I mean, the Prescription Digital Therapeutic Act that was sitting in the Senate and in the House in Congress was driven by Pear, and they were looking for a specific reimbursement code for a specific condition for their Reset O product. And it's like, Congress is never going to approve. Congress isn't going to approve anything these days. That's a different story. That's a beer discussion. But they're certainly not going to approve a single, one thing. It's not going to happen. And so I think what we're seeing is the payers are absolutely covering this, but it doesn't have to be through a reimbursement model. It can easily be through a SaaS model. It can be through a PUPM, PMPM, whatever your favorite. If you're demonstrating economic value and healthcare value, if you're showing that you're making a dent in their healthcare outcomes and you're making a dent in their costs, they will find ways to pay you. Absolutely. And I think that's been a learning for us too, that the way we work with many of our payers is that SaaS model. Again, scalable is something that they can, you're not looking for a square peg in a round hole with the coding, right?
Thank you for the question.
Can I ask you a question? Like, are you, because, in the food is medicine movement, right? We're focusing on that one sort of, medically tailored meal, right? What we're seeing is, and we're a small company, right? And so that funding bridge to get us over that edge, over that hump, so that when a large healthcare system or provider is finally ready to use you guys, right? They sort of want this market solution. So they want, like say the fresh clinical model, but they also want the medically tailored meal, and they want the food prescription program, and they want the digital platform, and they want the registered dietitians and the health coach as a one-stop shop, right? And that's where I think the struggle for, I don't know how you guys feel about that, for any sort of small, innovative company to sort of scale up to the point to offer what a provider or a health system or a plan wants.
Boy, we're hiring, Doc, by the way. I like the way you think. Our platform incorporates all of those things. In fact, one of the things we did during COVID, which we found fascinating, is you have diabetes-friendly meal recommendations, right? And you have hypertensive-friendly meal recommendations, heart failure-friendly, weight management-friendly meal recommendations. Well, we said, geez, let's go the extra mile. Let's put it in a grocery list. Let's go the extra mile. Let's add it to their Instacart or whatever, however they get their groceries delivered. we're the beneficiaries of what's happening in app world and technology world, that they're moving at a clock speed that's much faster than that of healthcare, right? And so today the platform accommodates all of that. It's all within there: food management, weight management, education management. And I think integrating that platform base that looks at all of those vectors and making it part and parcel of a payer's program. It's not some parallel universe. It's something that they run. It's their branding. It's how they integrate it into their care workflows. Those things are super important. And I think that's at least what we're finding. It ties to the earlier question about reimbursement. They will find ways to reimburse and pay you because you're creating value at that point, right?
Susan.
Yeah, I just wanted to comment because I think you raised a lot of good points about a lifetime cap. And just to state that there's short-term and long-term strategies. And so number one, Mayo Clinic wanted to, everything I'm about to say is off the record.
Please delete recording.
Because we want to have an open discussion, right? We want to send a very strong message to pharma that this is too expensive. And the economic data does not support the price of the drug. So number one. Number two, we are looking, as many of the people on stage are looking to do, is to how to get that patient to lean in to this problem. So just like an alcoholic, there's a day where you say, enough alcohol, I'm going to do something about this. My weight is at that point, I'm going to try to do something about this. And then what do I do about it? So thinking about all the types of patients, and this is early research, I'm not saying this is the answer, but starting to look at phenotypes of patients who have a hungry gut, hungry brain, or emotional eating habits. And how do we identify those folks with genetic testing, with survey testing? What's driving their eating? And the drugs are part of that solution, but so are Contrave and Qsymia. So when we go to emotional eating, we have some psychological components related somewhat to addiction going on there, potentially. And so the last problem we have is if you can only, because of your own finances and your co-insurance model, you can only afford your GLP-1 for a certain period of time, means you're going to come off it. 30% in the PRIME study were still on a drug after a year. So then we get this hyper appetite, and people are starving, and they eat and eat their way back to their original weight. So we need to increase their muscle mass, things like that. So those are the things we're learning, is how do we coach these patients to live with the drug, and then if they want to come off it, just like we do with mental health drugs, how do we get you off that drug safely so you can maintain and sustain, and maybe you revisit it in 6 months or a year when needed. So those are just a few thoughts. I'm sure a lot of you have ideas around some other things that we can do.
Can I make a mention? Go. I'm sorry. Go ahead.
No, I was just going to say, one of the things that we're looking at is infusing that behavioral component initially before they even get to the point where they have the option for the GLP-1, right? So even if they do need to go on it for a period of time and then come off, they've got those habits built in so that it truly becomes a lifestyle. That GLP-1 is not a magic pill or injection, I guess. There's no silver.
It comes in pill form, rebellious.
There's no silver, right? There's no silver bullet in this. And so that waiting period is what we're advocating for as an employer, not because we don't want people to go on it, but we want the right people that can get the best outcome from it.
So, as I mentioned, I just started this new role. So I'm going to oversee the integrative and functional medicine system for Catholic Health. And this is exactly to your point where we're going to be looking at that sort of root cause of weight. And a lot of times it has to do with the microbiome. And it's fascinating that this sort of GLP-1 is happening at the same time the explosion of research on personalized medicine, looking at food sensitivities, the role of the microbiome on leptin, on GLP-1s, right? And so that's sort of how we're going to be attacking this. And we're a health system, but we're also an employer. And we have our own covered lives. And so we're looking at our own employees in that sort of better weight, say, triage. And one of the hires that we've done is this patient navigator. And it's really important to have a patient navigator to truly understand all the services that we provide. So therefore, someone is just not going down that bariatric path or that sort of pharma path or that drug path. And so really sort of personalizing that approach, understanding the root cause of their obesity is what we're going to be launching in the next couple months. So great question. I totally agree with you.
Thank you for that. And we have Bruce here. And Bruce, we're going to make you the last question because the time generals over here will dock me. So please ask your question.
Quick question. What is your understanding of the experience in the Medicaid population with these drugs? Because it seems to me that whenever there are new ideas, new technologies, startups, and whatever, it always goes toward the commercially uninsured Beverly Hills crowd, and the problems are in the Medicaid population. No coverage.
Right. Well, what I understand through my research is, and I think Kaiser Foundation put a paper out. Different states have different rules on GLP-1. Some cover them, some don't. I think that it's very expensive for Medicaid, right? If that, just like Medicare, we know that Medicare is contemplating covering this. There's 42% of the Medicare patients are obese, so it could cost, if all the patients went on, it could cost Medicare $26 billion, when in 2021 they paid $2.6 billion for GLP-1s. And Medicaid, obviously there's some challenges there as well. Obviously, there's the MDRP program discounts, but despite that, it would still be very, very expensive. And I think hopefully what you've heard today is that we have to think about a different type of recipe, no pun intended, where it's much more holistic. And, I think it's like 3 out of 10, because Medicaid also covers the young, 3 out of 10 adolescents are overweight, obese, right? So the problem starts way potentially earlier in that population. So we got to think about something different. I think it has to be holistic and it has to be thoughtful, and there has to be continued pressure on pharma, right, to make sure that the pricing of these products correlates with the outcomes that they can generate. And maybe we have to think about more value-based arrangements to try to right the ship there. But I just want to thank all my panelists today. I think you guys did well. I think I'm going to get a good review. And thank you, everyone. I'll turn it back over to Ron Dottie.